Okay, good. So it's 4 o'clock. Welcome on this webinar from REGEDENT. Today we have the pleasure to welcome Professor Marcel Wainwright on a very exciting topic. I know that many of you were asking for that. Soft tissue enhancement with hyaluronic acid. So let's move to the second slide, where I'll give you a bit of brief about Marcel's background and expertise. So Professor Wainwright is a specialist in periodontology, in implantology, and in ultrasonic surgery. He got his dental education in the University of Aachen in Germany before going into private practices. He is the founder of the Nirala clinic in Stockholm, Sweden, and consults clinics in different countries like in Germany and in Switzerland too. Aside from his private activity, Professor Wainwright is teaching ultrasonic surgery at the University of Sevilla in Spain. He's also the co-inventor of Intralift and several ultrasonic tips with Action Satellite, and is the guest professor at the universities of Leuven in Belgium, Chapel Hill in the US, Maidol in Thailand, and Dalian in China. Professor Wainwright is active in several societies as member, vice president, president, and these societies are related to implantology, cosmetic dentistry, ultrasonic surgery, and dental fillers and neurotoxin education. Professor Wainwright went also to the German Olympic team, with the German Olympic team to Beijing and London as an official dental team support for the German team, which is something quite special. And finally, I would add that Professor Wainwright is regularly publishing in international journals about implants, soft and hard tissue, augmentation, ultrasonic dentistry, and so on. That's all from my side. Marcel, I will let you take the lead from now on.
Thank you very much, Alexandra, for the very extensive introduction. I welcome you, all my colleagues, in these very special times and very challenging times, and I hope that we will have in the next 1 hour the opportunity to exchange knowledge and get a little bit away from the bad thoughts that are like cruising around our minds with this pandemic. I hope everybody of you is like in a good health shape, and I will immediately start with this exchange of knowledge. So the topic actually, what we're gonna focus on within the 2 webinars is displayed here in this slide. Number 1 is for today, peri-implant and periodontal soft tissue enhancement with hyaluronic acid. And in the next webinar that we're gonna have next week, I will go into the details of papilla regeneration. Okay, so to explain a little bit about the hyaluronic acid, or I will name it within my presentation mostly HA because it's a little bit shorter and not so time consuming. This is an essential part in the extracellular matrix of all mammals. We will find in all our tissues hyaluronic acid. And one very popular attitude of hyaluronic acid or behavior is it bonds to water, which is in the skin or dermal filler treatment a very important fact. So what are the major characteristics of hyaluronic acid? It is bacteriostatic, it is fungistatic, it is anti-inflammatory, it is anti-edematous, pro-angiogenetic, it promotes the wound healing, and it's osteoinductive. This is just like examples for a vast numbers of studies that you will find on all the relevant libraries. So when I look at this long list, I see purely beneficial characteristics of hyaluronic acid. And actually it is like used in many other medical fields since decades, like ophthalmology, in pulmonary surgery, in orthopaedics. It is used since decades. Although it is documented in dentistry since another 1 to 3 decades, the capacity is pretty unknown of this beautiful adjunctive tool that we can use in a vast number of applications. One very big important fact is that the periodontal ligament is based and does need hyaluronic acid. So since we know that the PDL consists out of collagen, and the cells that are relevant for the collagen production need hyaluronic acid, I wonder why it is so unknown, the application in the periodontal treatment. We do have studies in abundance on that topic. If you go on PubMed, you will have a lot of time to go into detail with those application. But I picked one out from 2011 that focuses on the application in conjunction with periodontal surgery, that the results are significantly better with hyaluronic acid in comparison to surgery without. We go in the period treatment. Of course, it is a long question since many years, that what is the most effective hyaluronic acid for the period treatment, since we do have a bunch of elementary characteristics with hyaluronic acid here. So we need to see what is the best one to treat the period treatment. And we found out that the high molecular weight hyaluronic acid gels have the biggest outcome in terms of proliferation of those relevant cells, like fibroblasts, lymphocytes, and it does abate an inflammatory process. So this is bonded to the high molecular weight. In this study from Pernaza and Andrea Piloni were involved from Sapienza University in Rome, the average of the most effective hyaluronic acid for periodontal treatment was 1,300 kilodalton. This had the greatest overall effect. And this is something that is important to know. So high molecular weight hyaluronic acid is, per definition, everything that is exceeding 800 million Dalton. And that does potentiate the differentiation of the human monocytes into fibrocytes, which is a very relevant factor. Low molecular hyaluronic acid inhibits fibrocyte differentiation, and the receptor that is mediated by the effect of hyaluronic acid is CD44 and CD168. So whenever we will focus an imbalance between the production of hyaluronic acid and inflammatory processes, we will face problems. One very, very important factor is the bacteriostatic effect of hyaluronic acid, and it was many times discussed that there is no bacteriostatic effect, which is per definition, and if we look on those literatures, wrong. We know that one of the biggest leading dental or periodontal pathogenic germs, Treponema denticola, can be strongly inhibited throughout hyaluronic acid, which is as a clinician, something that I will go a little more deeper into detail and show in clinical examples how beautiful hyaluronic acid might work against those germs. CD44, as mentioned previously, is the most prevalent hyaluronic acid receptor. And I will show in this graph what it does with the two different cell-to-cell modulation and the cell-to-matrix interaction. So if you see on the left side, you see that CD44 as a receptor is important for the cell aggregation, for the traffic of those cells, what we call migration, and the release of growth factors. In the right box, you see the cell matrix interaction, which is based on fibronectin, collagen, cytokines, chemokines, and metallic matrix proteinases. CD44 and the hyaluronic acid T lymphocyte interaction is based on stimulation and the feedback of suppressor cells, which are cytotoxic, and the stimulation of B cell growth and the activation of macrophage system. So as you can see in this graph, we have a T lymphocyte. You see those little spikes on the blue balls, which is a simulation for T lymphocytes. And this is like bonding to the receptor CD44 and can crawl on the surface of the endothelium, can crawl the T lymphocyte and cause an adhesion, and can walk through the endothelium that is causing diapedesis. And if we compare the capacity of high molecular hyaluronic acid and low molecular weight hyaluronic acid and those who have none, you see in comparison that the strains of the collagens, which are highlighted here with those arrows, are bigger and larger compared to the groups with no hyaluronic acid and the low molecular weight hyaluronic acid. Let's go into the clinical aspects. I have here one case of a patient. This case is probably 8 or 9 years old. And this patient, female, 154 years at the time when she was showing up, had an implant that was placed by myself and a titanium abutment. This was a titanium implant as well. But she suffered after a while from bad taste when she was sucking at this in this area. She was causing blood. So she came up and we were seeing a mucositis. Due to the x-ray, we could not see any bone infection. So the treatment here was done and performed with hyaluronic acid. So what is the protocol of the treatment at that time? We did rinse first with chlorhexidine, 0.2%. And because chlorhexidine is interacting with hyaluronic acid, we need to get rid of the chlorhexidine. So we rinse afterwards immediately with saline or water from the unit to get away of all the excess of chlorhexidine. And then we did a blunt installation of hyaluronic acid. It is not an injection. It is just like an application with a blunt cannula, for instance, at that region that is infected or we see inflammation signs. The patient is asked for not to eat and drink for at least 3 hours and is sent back home. So we did this in a repetitive way after 1 week. And this is important that we should mention that a several treatment within 1 week with hyaluronic acid doesn't make any sense because the turnover of the relevant cells is 1 week. So what was the result? After 3 weeks, the patient came back And we did no other treatment, no laser treatment, no medical treatment, nothing else. And we took off the abutment. The patient was, after 3 weeks, where we did like 3 times this type of treatment, completely without pain. And after we took off the abutment, we could see very blunt, very sound, soft tissue behavior, no inflammatory signs. And that was, to me, actually the first time I could see the capacity of hyaluronic acid. Another clinical case where we could see within a very short time frame of 1 week was a patient, a female one, 72 years at that time, she was showing up, that was complaining about inflammatory signs and pain on the lower molar on the left side. It was the first molar. So you see on the left slide, you see the probing depth and immediate BOP. And we did the same following the protocol. So we rinsed first with chlorhexidine, get rid of the excess of chlorhexidine with saline. And then we did the blunt installation of hyaluronic acid into the PDL, into this groove. So we did this from all aspects, lingually, mesially, distally, and buccally. 1 week later, the patient came back, and you can see that the bleeding on probing had been reduced tremendously. Even the pocket depth was reduced a bit, and the patient was immediately without any pain after 1 or 2 days. So we see the inflammatory capacity of hyaluronic acid displayed in these 2 cases very nicely. Here is, in this graph, you see the capacity of reduction of BOP that was performed with hyadent from the company REGEDENT. And you see that the combination of ultrasonic scaling and application of hyaluronic acid compared to the purely use of ultrasound showed a better outcome, a better performance with hyaluronic acid within a time span of 90 days. So BOP could be reduced dramatically in the combination of both. In our protocol of periodontal and gingival treatment, we see, I want to show you here different steps that we do follow. The first thing is we do a very intense examination of our patients. We can check all those parameters you're used to. We do a MMPA test to check the inflammatory rate in the gum. We check, for instance, if necessarily, we do a bacteriogram. And you see that the treatment of the gingivitis and the periodontitis is following different steps. If we have a gingivitis and a good compliance and a good oral health care of the patient, we do an intense cleaning. Of course, with the gingivitis, there is no affection of the bone, and probably we go with a photothermic therapy. The next step is that we do a control after 2 weeks to remotivate the patient. And then we do, when everything has been cleared and healed, we do a recall every 3 months, which in my personal opinion is mandatory to all of our patients, especially on those patients where we deal with implants, because a time frame of 3 months is something we can deal with. If we ask the patient only to come back into the office in 1 year, that is not enough. And the periodontal treatment, if we have a periodontitis, it is based on the same treatment protocol like gingivitis, but here now we probably use, in addition to the photothermic therapy, we use a diodium laser. we do a control after 2 weeks. We do test again the MMP8 value, or we do a bacteriogram. And then here is the major difference. Now we want to regenerate the PDL. And since we know that the PDL does need hyaluronic acid, we start with the regeneration here with hyaluronic acid. And after 3 months, when everything is set, we do again a test. We check again the metallic matrix proteinases 8. And if everything is like stable, we ask the patient to return back after every 3 months. I will go now a little bit more into clinical application of the hyaluronic acid. As you can see here in this slide, here we see on the left picture a crown and a typical case of violation of the biological width. So the crown margin here was way too close to the bone level, and the patient had, of course, inflammatory signs. He was not happy with the aesthetics of the gingiva, and he had some issues, of course, with bleeding. So what we did was here, we were trying to replace the biological width. We did this surgically with a marginal incision. I do this basically with ultrasonic tips. So we were reestablishing the biological width. And within this surgery, we want to stabilize and to enhance the soft tissue. So immediately after the surgery, we do inject with a sharp cannula the hyaluronic acid. And you see on the right slide, this was after a pretty short time, I guess after 1 week, we see immediate stabilization of the soft tissue. In conjunction with surgery, we use hyaluronic acid as well as a standardized protocol. So you see here one case, a young lady with a bridge who was not happy. As you can see here, we have a deficiency of the soft tissue, especially in the region of the lateral incisor. So the plan was here to graft this site with a connective tissue graft, as well as to enhance the outcome of the soft tissue. Because my preliminary goal is when I look on the soft tissue, I address how much of soft tissue do I have? What is the biotype? Is it a good biotype or is it a bad biotype? Is it a thick biotype? If I want to switch the bad biotype into a good biotype, I do this either with surgery or in many cases in a combination with surgery and hyaluronic acid. But sometimes, as I will show you later, in some cases, we can shift purely with hyaluronic acid the biotype from a bad biotype into a good one. So the surgery here was, we did a tunneling approach. You see very close to the blue arrow, one stitch. That was my vertical incision line where I was preparing a tunnel for my connective tissue graft to stabilize and to volumize this deficient ridge. After this, we were giving information with a temporary acrylic temporary bridge to the soft tissue. And after a healing period of 6 to 8 weeks, we go back. And here you see prior to the final treatment, we were doing a veneer as well, but we were redoing this bridge with a zirconia bridge. And look here in comparison to the soft tissue before and after. It is pretty difficult here to see where we do have a pontic and where we do have a crown. So you see, we were not only stabilizing the soft tissues, we were actually enhancing the soft tissue and shifting it from a less good biotype into a good biotype. And we were giving smile back to the patient. Here you see a combined surgery where we did a frenuloplasty. This was performed with a laser in conjunction with an implantation of an upper central incisor. You see here that we have some gingival irritation after 3 weeks after loading of those 2 central incisors. And we did purely inject sharp here in this region with the syringe hyaluronic acid. You can see within a very short time, in a few weeks, that the soft tissue was completely regenerating. And it is hard to determine that there is any difference between those 2 central incisor implants to the adjacent teeth that are natural regarding soft tissue appearance and stability and thickness of the gingiva. If we want to improve soft tissue, I show you this case where we had like an implant. You see the stitches, and we did frenuloplasty here. And we were doing an immediate implant, and you see that the soft tissue here was a little bit deficient at the time where we were loading this implant with a temporary crown. But you see a blunt healing, because not only the region where we did place the implant was getting better, even as well the frenuloplasty where we're using the laser. After 3 months, where the patient was incorporated with those 2 acrylic crowns, temporary crowns, you see that the thickness and the volume of the soft tissue has increased tremendously. You see it's way thicker than before. You see the volume is way better than before. And it is not only the quantity, but the quality that could be enhanced with hyaluronic acid. So let's go back or go further to another clinical case. You see here this patient with a central incisor, and you see there's something going on with the soft tissue. You can see those little red dots, lateral and apical from this tooth number 1-1. And the soft tissue does react. We had here a root canal treated tooth with a CAP that needed to be extracted. So what we did was we did an extraction, we did an immediate implant, and we did inject hyadent immediately into the tissue, immediate after the surgery. And this is the outline of the injection following the gingiva around the tooth or the implant. And I will show you later where and how we do inject and what is necessary to know. 6 weeks post-op, you see a much better appearance of the soft tissue. You see a volumizing of the soft tissue. You see a nice stippling of the soft tissue. And you see that the biotype is excellent. And to show you how we can shift, I start with where we started with the beginning, which is on the left slide. And on the right-hand side, you see what we could achieve within a couple of months. It is a complete different gingiva. And I want to note that we didn't use here any connective tissue graft harvested from a donor, intraoral donor region. We did this purely with the injection of hyaluronic acid. And this is to me something that I want to have, not only a nice crown on my implants, but I want to have very stable soft tissue appearance to make sure that this result later will be stable as long as possible. Another clinical case, we see here an immediate implant placement. this is the upper view, just to display the soft tissue and the thickness of the soft tissue and the volume of the bone. So we placed here as well an immediate implant, and we did inject with a sharp cannula, with a sharp needle inside the tissue, the hyaluronic acid. You can see here probably where the green dot is, that we achieve here some sort of a blanchet effect. And this is actually the point where probably material will exceed out of those little collagen tubules, because I'm pretty often asked how much volume or how much material do I need to inject into the tissue. The very easy answer on this is that you inject until you have an excess of material coming out. So, and you will see this blanchet effect. Important is that you do inject slowly, which we'll see later on in the video. So here you see this central incisor, 4-month post-OP. You see after several injections with hyadent, a pretty much stable and nice biotype of gingiva and very stable soft tissues. Here you see the mirror picture, and again, note the quality of the soft tissue compared to the adjacent natural tooth. It is completely no difference. We see a very nice result that was based on the adjunctive use of hyaluronic acid. Of course, you can use hyaluronic acid in combination with bone augmentation as well. And here is one clinical example where and how we do use it. We do mix our biomaterial with hyaluronic acid, with hyadent, to make it a little bit better in cohesion. So what you can figure out is that any kind of bone grafting material is way easier to apply inside those voids that needs to be grafted. Number two, we give a biological information with all those attitudes of the hyaluronic acid that was displayed in my very first slides. Anti-inflammatory character, cell stimulation, cell proliferation, all those very important things we add to the biomaterial, and we coat the biomaterial with a very biological coating. After the graft surgery, we did inject from the outside, we did inject the hyaluronic acid with hyadent. As you can see here again, you stop when you discover a blanchet effect and when the material will have some excess. So that is like the point where you should stop. What is the complex case? And we'll show you where we deal and how we deal with the treatment of complex cases. And I want to assure you that hyaluronic acid and this beautiful material I use is not like something like a miracle or something that is on an experimental application level. I use it standardized because I've seen that it is enhancing all kind of my surgeries. It doesn't matter whether it's implants or bone grafts or soft tissue manipulation. It is enhancing all types of my surgeries and make things better. And I know that those who are questioning sometimes, especially the papilla augmentation, I will go very much in detail next week on Thursday to this topic. But let's look at the complex case. This is a young patient. He is 30 years when he was showing up. And this patient here had an issue with a central incisor. You see, it's like a little bit darkish. It was a root canal. He had some fractures, and we needed to to take this tooth out. If you look at this side, we see a challenging situation. We have a very bad biotype around the natural tooth. We do have a compromised bone situation with not a complete loss, but a semi-loss of the buccal plate. And this is challenging to achieve here with implants. A result that is on a long-term predictable is not that easy. So we started with placing an implant in the right prosthetic plane. And of course, we needed to graft that side. We were using here grafting material, a mixture of anergenic material and bovine material. And we were adding as well hyaluronic acid, which gives us here a little bit glazy appearance. We're using hyadent here to enhance it. So on the right slide, you can see the post-op X-ray immediate after implant placement and grafting. And of course, we did graft in excess because we expect some remodelation, some loss of the bone grafting material. So we need always to think a little bit in plus. We were cutting his natural tooth and we're bonding his natural tooth after we did some polishing of the lower part of the tooth that is facing the soft tissue to the adjacent teeth with a flowable composite resin material. 7 days post-op, you can see that we do have an uneventful healing. And we started here at this period with the injection of hyaluronic acid in the tissue, which is performed with a sharp needle. Here you see we do have uneventful healing, but a little bit deficiency in the soft tissue. 5 months post-op, after we did in a repetitive way the injection, we asked the patient to show up in the clinic every 3 weeks. 5 month post-op, we asked the patient to return back for second stage surgery, where we tried to load this crown or the implant with a temporary peak abutment and a temporary crown based on acrylic. You see here the temporary peak abutment, and after preparation, we were doing here another additional soft tissue and hard tissue enhancement, only a hard tissue enhancement with some bone grafting material. And this was immediately after the surgery. So we were redoing now the TEM, we're taking off his natural tooth, and we were using now here on the peak abutment on the titanium implant, a acrylic temporary that is shaping already a little bit the soft tissue. Immediately after the surgery, we continued with the injection of hyaluronic acid. And as you can see here, after 2 weeks, we see more and more stable soft tissue. And this is 6 months later. So the total treatment time of this was 10 months, which is a pretty long time, but regarding to the defect we had, like regarding the soft tissue compromise and the hard tissue compromise, we do have here a very nice result before and after. So you can see here again, in this very challenging case, it was not an easy case because the patient was, in addition to the bone and soft tissue situation, he was a smoker. And of course, we always ask the patients that do smoke to stop smoking or at least to reduce it, but he was not willing to do so. So of course, we clarified everything that the result will, of course, be depending on his behavior. He was completely not following our rules, but you see, anyway, a pretty nice result regarding the soft tissue. So the sharp injection with hyadent The application is done like this. The sharp injection, you have a sharp needle, 27 gauge, 30 gauge, whatever you have in your hands. And you can place this hyadent carpule into your syringe and slowly inject it into the tissue. It is important that you don't apply too much pressure. And whenever you see this Blanchet effect, whenever you see that the soft tissue is giving access to the material, then you know that you should stop. And if you do surgery, my recommendation is place some of the material on top of the sutures, because it has an antibacterial effect, and it will do its job a little bit like gluing those suture ends together. Why do I inject inside the tissue? It is important to understand how hyaluronic acid does work. We do have a higher expression of the vascular endothelial growth factor when we have a higher amount of hyaluronic acid in our tissue. So what is like very important to me is that we try to achieve as fast as possible a very good blood support of any grafted area. It doesn't matter if you do hard tissue augmentation or soft tissue augmentation, we need a high expression of VEGF. And I love this chart because it is showing that hyaluronic acid within a time frame of 6 to 8 days is like lifting up the VEGF expression and the numbers of blood vessels, which is absolutely important to me. So what is the take-home message? Hyaluronic acid is a very safe and easy to apply and predictable tool to enhance soft tissue and hard tissue outcome in conjunction to the existing techniques. And this is so important for me to make this paramount, because I would not say that hyaluronic acid can do everything and like do miracles, but in conjunction to those existing techniques and appliances that you're using every day in your clinics, it is able to show a massive increased outcome of your result. So in conjunction, to me, based on the science and the long-term results that we do have within the last 20 years now, I do definitely rely on the application of hyaluronic acid. And I will go now in the last 15 minutes to those questions that are popping up here. And I hope that you enjoyed this webinar, and I will go now to go back to those questions. I start with one question here that was placed by Alexandra. The first case you showed, it was a case with mucositis. You removed the plaque, and then did you apply hyaluronic acid? No, we did in this case purely take off the crown, and we were doing the protocol. We did rinse, we did apply the hyaluronic acid, and we did this in a repetitive way and waited. This was just like done on purpose. Of course, today I do recommend that you use any cleaning devices like ultrasound devices, or you use a laser, or you do the manual cleaning of this site. But we wanted to show that purely with the application of hyaluronic acid, we will have an increased situation compared to the high inflammatory reactions we had when we started the treatment. So this is something that we wanted to show. Another question is hyaluronic acid inactivated by blood? How do you clean the site? Absolutely not. It is not inactivated by blood, because in the bloodstream, or when we see a bleeding, it does actually bond very nicely to the blood, and you can use it even when you do grafts, where it is not possible to exclude any bleeding in the recipient site. Another question was, do you irrigate the hyaluronic acid into the sulcus, or do you infiltrate the hyaluronic acid inside the connective tissue? I would say that way, when I do have to treat periodontal problems, I would first, of course, irrigate, and then the application is a blunt application inside the sulcus. So I would not inject it with a sharp needle, because otherwise you could destroy the PDL with your needle. So that's the reason why I use a blunt cannula to apply the hyaluronic acid inside the sulcus. We have further questions. Is it possible to gain papilla height using hyaluronic acid? This is a question that I will definitely give an answer to next week, and I can make a long story short. Yes, it is possible to gain papilla height, but we need to do a proper case selection, of course, and we need to check primary the conditions of the patients. But I will give answer to this next week, and I show you in videos and in many cases how beautiful we do apply in our daily clinics, clinical application, the hyaluronic acid to gain and to enhance papillas. Another question was, do you use a membrane when you mix the biomaterial with the hyaluronic acid? There is studies from University of Bern and studies from Sapienza University in Rome that show that both does work, either with a resorbable membrane and without a resorbable membrane. My personal opinion is, if we leave the periosteum intact and we have no violation of the periosteum, then it is due to the effect of the hyaluronic acid that is like gluing those little particles together and like embedding it. It is not a compulsory need to use a membrane. If you feel better to use a membrane, whatever does work in your hands, I would say use it. But we need to understand, if we use a resorbable membrane, how does this resorbable membrane dissolve by itself? We do have always a higher inflammatory response due to the degradation of the resorbable membrane. We have a high expression of inflammatory cells, which is normal when we use a resorbable membrane. So probably my personal advice would be, if possible, you should use a non-resorbable membrane in conjunction with hyaluronic acid. But there are studies that show as well that both does work. One question was, HA injections in aesthetics usually disappear with time, so the patient usually gets new injections. Will this also happen in the gum? Is this a rather temporary treatment? I will put this question regarding papilla treatment. I can assure you that we are having here two different mechanisms. In the skin, we have another reaction. In the skin, it is purely used as a volumizer. In the papilla, what we do is we create a new room with hyaluronic acid, and in this new room, we see a migration of new cells. So the outcome or the long-term results of this, I do have in my next presentation next week a lot of answers to this. Is in my hands so far at least 4 to 5 years stable. I don't know if it is stable forever, and I would never promise this my patients, but it is pretty long stable in those cases I've treated. Then there is a question, do you have stability for long term? Okay, here once again, we need to look on 2 different application fields. The one I was dealing today was hyaluronic acid in conjunction with surgical protocols for soft tissue manipulation. Here I do have absolutely completely long-term stability, because we do not only enhance the soft tissue by injecting and volumizing it, but we change the biotype, as you could see in my previous cases. The papilla treatment is another story. So here is, again, a different story, because we do use here the papilla injections for a time frame of 6, 7, 8 years now, and the follow-up is approximately 4 to 5 years. So here it is something that is where it is stable, but I don't know if it is stable for longer than 4 or 5 years. But I asked my patients actually if they would mind if I need to redo the injections every 4 or 5 years, and everybody was positive with this. Here is another question. In endodontic surgery, is it applicable? Yes, definitely yes, in all types of endodontic surgery. And when you are asking like epicoectomia, then I would say definitely yes, because in all my kind of surgery where I applicate hyaluronic acid, I do have less pain, less swelling, less complaint, faster healing, better outcome post-op. Then we have a question. I wonder if there is any study on the effect of HA on the cementum of the tooth, like cementum regeneration. Very good question. And I need to be very frank. I don't know actually if there is a study that is like dealing with this topic. I will check it out and probably will get an answer on this next week. But I need to be frank, I absolutely don't know if there is any study and publication on cementum. That was the next question. For the subsequent injection of HA to increase tissue volume, do you anesthetize the area separately, or is the lidocaine compounded with the HA in the carpule? I would say it is depending, of course, on the sensitivity of your patients. I experienced that it might be pretty uncomfortable for the patient if the area is not numb. You can either use a topic anesthesia, like a gel that you could preliminary like place on the area where you want to inject it. But I figured out that a little injection in the vestibulum could be a help, and especially in sensitive patients. I did both. I had patients that were not reacting, not even blinking for a sec, but I don't see the need to give a patient trouble. Happy to see that Maisie Elazir from Bern. Big hellos, and thank you for your research. There is a question in osteonecrosis. Well, I think the pure application of hyaluronic acid is something that is not like understood on a scientific way in osteonecrosis. Probably in an adjunctive, as an adjunctive tool, but I would rely here probably on other therapeutical ways. There is one question. She's a volunteer concerning pandemic situation, and she would like to ask if she's registered, if I have registered this lecture so I could listen to it later on. I think yes. I think we do have this this lecture later on where you can see it, and we will give an answer to it. I think. Do we have it? Question to you.
Yes, actually, it will be posted on the website of REGEDENT, and it is also on the Facebook wall of REGEDENT, so you can access it.
So, okay. So this will be not only for today, you can go through this in a multiple way. One question was the comparison to Emdogain. Okay, of course, Emdogain is a beautiful product as well, and I do have long-term results and good results with Emdogain as well. But this is just another story, because we do have sometimes patients that are a little bit questioning the origin of Emdogain. And as we know, this is porcine origin, especially those patients coming from Arabic countries with Islamic belief. They were not happy to have a material. So what I like on this hyaluronic acid is that it is something that we do have anyway in our body. And since there is no cross reaction, since the production of this hyaluronic acid is based on bacterial production, there is no interference with genes compared to the hyaluronic acid that is based on Rusocum. So another question, segmental tear-associated bony defect using hyaluronic acid and a resolved collagen membrane. Okay, this is the study from Andrea Piloni. Thank you for adding this. And another study from Lopez and Carinci, Perspectives in Dentistry, a Systematic Review. Okay, there is a nice add-on from colleague Ki Matar. I hope that I'm pronouncing it not too bad. So probably we'll add those studies in comparison with collagen membranes to your follow-up, and studies there like dealing with this topic using HA with a collagen membrane. There's a comment from Maisie Alizier. So I will give this as well. Collagen membrane with hyaluronic acid on diabetic situation could help to slow down membrane degradation by reducing the inflammatory process. And thank you, Maisie, for this mentioning of your publication of this paper, because it does make, of course, sense. If we do coat the collagen membrane with hyaluronic acid, we give all this the effects of hyaluronic acid, like reduction in inflammatory response and all those I've displayed in this table. We give all this information to the collagen membrane, and of course the degradation is way better. And then we have here a question if there is any histomorphometric studies about the better outcome of HA associated to bone graft versus the bone graft alone in GBR. I would say that there is studies already performed dealing with comparison HA with bone graft versus bone graft without. I do assume that there was performed as well histomorphometric analysis of this. We will place this on the website of REGEDENT, so you can for sure have access to this to these studies. How do you treat patients with chemotherapy? Very good question. All kind of patients that are completely compromised in their immune response, I try to rely on as much as least invasive treatment protocols. So hyaluronic acid, as we know, which is prevalent in all types of our tissues and doesn't show any reaction to in a foreign body manner, this is the material I use definitely in those compromised patients with a reduction in immune response. And for sure, I would not use in a patient with radiation or chemotherapy. I would not use any material that is based on animal origin. So I like here to rely on the very good effects of hyaluronic acid, especially in those compromised patients. Here's one question: how can I assure that there is no tissue necrosis? I do assume that this question is related to the fact that we will see a Blanchet effect. So, of course, especially you need to pay attention in the papilla treatment, which I will very go much in detail next week, and with the video as well for the injection of the papilla. You will definitely see that if you apply this in your surgical protocols, you don't need to be afraid when you inject the material. Whenever you have reached like an excess, you will see it. In the papilla treatment, it's another topic, because you need to know exactly where to inject the material and where not to inject, because there are some risky zones that I would not recommend to inject. But this is going to be answered next week, very detailed, where and how to use hyaluronic acid in conjunction with papilla augmentation. Another question is if I do mix it with the bone during augmentation. Yes, definitely yes, as I was showing it previously. We do have from Tony Scullion beautiful studies based on that topic, that we can see that the performance and the outcome of particulate material used in grafting procedures can be enhanced with hyaluronic acid. Definitely yes, definitely yes. All right, so I don't know if I have completed now all these questions. I think so.
I think we've been through most of them indeed. Thank you very much for taking the time to answering them. To anyone, if you have more questions, do not hesitate to send them to us, to REGEDENT, and either we'll answer them by ourselves or we will direct them to the expert. I hope that this session was interesting. You will receive shortly after the webinar a short survey with 4 questions only. It would be appreciated if you could answer them. That helps us to improve our webinars, but also helps us as a small startup to provide you better services. I would like to do a special thank you to you, Marcel, for the quality of this presentation. And we've seen that the attendance kept on rising. So it's a real-time buzz that happened here. Well, we look forward for the next session next week about papilla. Thank you very much.
Thank you very much. Thank you for your attendance, and dear colleagues, please stay all healthy, and hope I will see you soon physically whenever these crazy times are over. Please stay healthy and enjoy your day and make the best out of the situation. All the best. Thank you to you, my friend, all those REGEDENT beautiful staff. You did a tremendous job in organizing this and helping me a lot. And I really appreciate the collaboration with you. I'm 100% convinced about not only the product, but as well on the company. Thank you so much.
Thank you very much. Thank you for these nice words. Bye-bye.
Bye-bye.